Let us revise what movements occur at the upper extremity. The scapula moves over the thorax. It elevates, it depresses, it externally rotates, it derotates, it protracts, and it retracts. So these are the movements between the scapula and the thorax, these 6 movements: elevation, depression, external rotation, derotation, protraction, retraction. And therefore these movements are called as scapulothoracic. Then the humerus moves on the scapula, which is the scapulohumeral joint or the shoulder joint. And this is a triaxial joint. That means there is flexion extension on the lateral to medial axis. There is internal or external rotation on the supero-inferior axis, and there is adduction and abduction at the antero-posterior axis. So the 3 axes of the shoulder joint, and flexion, extension, external, internal rotation, adduction, abduction are the movements that occur at the shoulder joint. Now the radius and ulna move over the humerus, and this joint is elbow joint. And since it is a hinge joint, there are only 2 movements: flexion and extension of the elbow. Then the radius moves over the ulna, and this movement can be supination or pronation. Then on the wrist, between the radiocarpal joint and the intercarpal joints, there can be palmar flexion, there can be dorsiflexion, there can be radial deviation, there can be ulnar deviation. At the so this occurs at the radiocarpal and the radial ulnar joint. Now there are 2 movements that occur at the carpo-metacarpal joints, and those movements are that normally the thumb is at right angles to the fingers, but then if the metacarpal rotates, it can come into this position and it can start opposing the fingers. So this is true with the thumb or the pollex, and this is also true with the little finger. So this little finger is normally parallel to it, but can rotate and come into this position, perpendicular to the axis of movement of fingers. So this movement, which makes the thumb oppose the fingers at the carpo-metacarpal joints, is called as opponence. Then at the metacarpophalangeal joints, there is flexion, there is extension, there is adduction, and there is abduction, and there is no rotation. At the proximal and distal interphalangeal joints, there is only flexion and extension. So you must do these movements and actually memorize them from above to below. And then we will start working on a 3D concept as to how each of these joints move. So we'll consider the scapulothoracic joint first. This is elevation of the scapula, this arrow, elevation. This is depression. Moving this way is protraction, moving back is retraction. Moving on this axis like this is external rotation, moving back is derotation. So these are the movements of the scapula. Now let us consider the muscles that produce these movements. The elevation, the levator scapulae and the trapezius will elevate the scapula. If the levator scapulae is really contracted, then there will be a high shoulder, which is called as triangle deformity. If the levator scapulae is converted into a bar, the bar is called as the omovertebral bar. So trapezius and levator scapulae elevate. Depression is by the pectoralis minor pulling the coracoid downwards and the lower fiber of the trapezius. So trapezius can depress and elevate both. Then protraction, here you see the vertebra, here you see the rib, here you see the triangular area of the scapula seen from above. From the medial border of the scapula going to the rib is the serratus anterior muscle. This pulls the scapula forwards, and that is called as protraction. Also attached to the medial border is the rhomboidus major and minor, and it pulls the protracted scapula backwards, which is called as retraction. So the protraction is produced by the serratus anterior and retraction is produced by the rhomboidus major and minor. And the fibers of the trapezius that connect to the spine of the scapula. So this produces retraction. Now, if the serratus anterior is supplied by the nerve to serratus anterior, root 5, 6, 7 root, and if this is paralyzed, and you ask the person to push forward a wall, there the inferior angle of the scapula will become more prominent, and that is called as winging of the scapula. And so winging of the scapula is diagnostic of serratus anterior paralysis. Then we will go on to study external rotation. You see the trapezius pulls up the spine of scapula from the lateral to its axis, and the lower fiber of the trapezius pull down the spine of scapula medial to the axis of rotation, and they produce this rotatory movement. And therefore, the deltoid tubercle is the axis of rotation of scapula starts, and it goes up to the sternoclavicular joint. It is on this that the scapula rotates externally. So trapezius rotates it, and it's held by the serratus anterior. Same way, if there has to be a derotation, this is the axis, then the levator scapulae will pull this portion up, and the pectoralis minor will pull this portion down, and there will be a derotation. Then we study the scapulohumeral movements. They are internal and external rotation. So internal and external rotation is at the axis, which is the supero-inferior axis through the shaft of the humerus. Internal rotation will be by the subscapularis attached at the lesser tuberosity and by the pectoralis major attached at the lateral lip of the bicipital groove. So these muscles will internally rotate. If you try to see what is below the subscapularis, which will also internally rotate, then it is the bicipital groove, where there is the lady between two majors. That means latissimus dorsi and teres major will also internally rotate because they are attached. On this lip is attached the teres major. On this lip is attached the pectoralis major. And what will externally rotate? The SIT structures, SIT, supraspinatus, infraspinatus, teres minor, especially the infraspinatus and teres minor, and the latissimus dorsi. So supraspinatus, infraspinatus, teres minor will internally rotate. Now, what will abduct? The first 15 degree, the supraspinatus, the up to 90 deltoid, and then the scapula will rotate on this axis, powered by the trapezius and the serratus anterior. So above 90 degree abduction is produced by scapulothoracic rotation. The muscles of the anterior and posterior axillary fold, the pectoralis major in front and the latissimus dorsi behind, will basically adduct the humerus, but in between the coracobrachialis will also help. So these are the folds, the pectoralis major fold, the latissimus dorsi fold. And the deep fascia of the axilla goes from here to here, and it is suspended by the suspensory ligament coming from the pectoralis minor lateral border. That you remember. So this muscles of the posterior and anteaxillary fold plus coracobrachialis will adduct the humerus. Now, this is what you see. The posterior axillary fold is latissimus dorsi, the anterior axillary fold is pectoralis major and the teres major. These are the muscles that will adduct, but the coracobrachialis is the original adductor that was adducting the humerus. Finally, if this is the clavicle and this is the acromion in the spine of scapula, and the glenoid cavity somewhere here, there will be the head of the humerus, the lesser tuberosity, the bicipital groove, the greater tuberosity, and all this is going down. Then arising from the anterior part of the lateral border of the clavicle, around the lateral border of the acromion, and then the spine of scapula up to the deltoid tubercle is a muscle which is attached to the deltoid tuberosity. Now this is the deltoid that abducts, but this portion of the deltoid really abducts. This portion abducts. So this is the abducted deltoid. This part of the deltoid which is anterior is the flexor deltoid, and this part of the deltoid which is posterior is the extensor deltoid. So this finishes the